Okay, dear listeners, dear viewers, dear candidates, welcome to this lecture, which is titled Principles of Airway Management. My name is Andrzej Barwinski. I'm one of the consultant anesthetists at Torbay Hospital in Devon in the southwest of the UK. I'm a Part 2 examiner and past immediate chairman of the examination committee. Let's talk about the principles of airway management. They could be divided in what we do in operating room, in intensive care unit, in obstetric units, and in emergency departments. This is obviously intra-hospital medicine, but this is where we as anesthetists mainly deal with normal or abnormal airway. We can also divide management of the airway into stages, into preoperative stage, where we take the history, we perform examination on the patient's airway, we perform investigations, we then move into intraoperative management, where we mainly deal with oxygenation, airway access, and ventilation. And then, of course, the postoperative airway management, which is mainly, again, consists of extubation, immediate or postponed. I'm not going to talk about that part of the postoperative or the extubation, but I refer you on this slide. There is a link to a DAS website where you will find the DAS guidelines on extubation, and I urge you to read that because that is also important. Due to the fact that quite a lot of times the difficult cases, difficult problems with the airway occur, not just at the perioperative period, but also preoperative period, but also postoperatively. Okay, so let's talk about the intraoperative airway management. I'm not going to concentrate on tests, how to assess the airway. I'm going to more concentrate on intraoperative airway management. So what we do is we provide oxygenation, or better to say, peri-oxygenation. So we should be really providing oxygen, not just before and then having an apneic period, but throughout the airway manipulation. And I will tell you and show you how it is done in modern settings. Then we provide the airway access, and then finally we start ventilation of the patient. Again, the ventilation is a huge, big subject, which I'm not going to touch in my presentation. My presentation largely will be based on 3 guidelines which are issued by the Difficult Airway Society. There are other guidelines that you might be aware of, and pretty much any airway society of this planet decided to produce their own, but they are similar. And of course, being from the UK, liking the system, and most of the world does like the system as well, I refer you to 2015 DAS guidelines on management of unanticipated difficult tracheal intubation in adults. We're not going to talk about pediatrics today. And let's take them in parts. So the first one, it's subdivided into several parts: Plan A, Plan B, Plan C, Plan D. This is all very important because during your examination, particularly during your SOE, your clinical SOE, usually it's SOE 3, could be an SOE 4, you will be most likely to be asked about how do you manage the difficult airway, or there will be a scenario that will involve a difficult airway. And that's what you have to remember: Plan A, Plan B, Plan C, and Plan D. And I will take them in turn. So in Plan A, look at the first one. It says optimize head and neck position. And if you're asked, how would you do that? This is the aim for you to achieve. It's basically quite often is required for obese or morbidly obese patients. And your aim is to bring the ear, the tragus of the ear is that little bit there in the middle, above the sternal notch by elevating the head. This is ramping, which is done in a sort of DIY fashion, do-it-yourself fashion. But there are now devices that can help you with this. This is head elevating laryngeal pillow that you can obtain. And see, this is the obese patients, which is having supports for his arms, and also this wedge that goes under his back, and also this pillow that his head goes into with like a groove, basically putting his head up, putting his him into a what we like to achieve, the famous sniffing morning air position. Okay, so the next one is pre-oxygenation, or better we say peri-oxygenation. How could this be achieved? This could be achieved in a variety of ways, and a variety of acronyms has been suggested for that, like no desat, meaning no desaturation throughout the airway manipulation, NODI, which is nasal oxygenation during induction, and also all singing, all dancing, transnasal humidified rapid insufflation ventilatory exchange, which is shortened to an acronym of THRIVE. Obviously, the one on the left, you can only give 15 liters per minute of dry oxygen, and that is very uncomfortable on the awake patient. So don't try 15 liters through nasal cannulas on the awake patient. Put it to about 3 liters when you send them off to sleep, and then increase to 5 liters. And then when they're asleep, you can increase it to 10 liters per minute or so. And that way you can provide peri-oxygenation. So don't substitute it for normal mask pre-oxygenation. This is on top of the mask pre-oxygenation, because again, through mask you can only give 15 liters. So together with this, you can achieve up to 30 liters, which is almost matching your inspiratory flow rate. But transnasal, but THRIVE gives you up to 70 liters per minute, so double your patient's inspiratory flow rate. Plus, this oxygen is warm and humidified. So it is very, very easy to tolerate high flows, 30 to 35 liters per minute in an awake patient. Then you can increase it to up to 70 when the patient is asleep and provide oxygen throughout the airway management. Is it effective? Yes, it is. Look, this is a paper which is called Pre-Oxygenation Using High-Flow Nasal Oxygen versus Tight Face Mask During Rapid Sequence Induction. So this group was testing from Karolinska and other hospitals throughout Europe, were testing whether this method is as effective or is more effective than the normal face mask pre-oxygenation during rapid sequence induction. And look, in red dots, there are high-flow nasal oxygen, 50 to 70 liters per minute for 3 minutes. And in blue dots, there are oxygen masks for 10 liters per minute for 3 minutes, okay? You can see that the majority of those are above the 93% line that they drew as the acceptable pre-oxygenation. And that is, at the bottom is the apnea time. So the apnea time, in some cases, were up to 500 seconds, and yet patients did not desaturate. Some did desaturate, but not many. But let's have a look at what their conclusion was. Their conclusion was that out of 175 patients in the face mask group and a similar amount of patients in high-flow nasal oxygen group, only 5% desaturated in one group and 6 in another group. So 5 in nasal oxygen group and 6 in face mask group. So this is the same. Basically, around 3% of them desaturated. So this method is as effective as the normal face mask, tight face mask pre-oxygenation. So use it. Ask yourself, do you have this device? If you don't, persuade your seniors and your management to buy you one. Let's move on. Direct or video laryngoscopy, it says there, maximum 3 plus 1 attempt. And I urge you again to use as much as possible video laryngoscopes, and there are a variety of video laryngoscopes around these days. Normal type, by normal I mean Macintosh shape size video laryngoscope or channel type video laryngoscopes. There is now even a classification of video laryngoscopes, but this is the main two groups: Macintosh type and channel type. Out of channel type, AirTrack is very widespread, and out of Macintosh type, it is CMAC, it is GlideScope, McGrath, many others. But basically, lots of people ask me, why is it 3 plus 1? Basically, 3 is for you, and the third one is for more experienced person. But people also ask, well, why don't we use video laryngoscope straight in the beginning? Which is a very good question, because and I say, yes, use it, particularly if you expect a difficult intubation, difficult airway. Why try with something inferior where you have visual laryngoscope? So go for it as a first attempt. And my personal preferences are these two devices, CMAC of Storz and McGrath. One is got a very big screen, which the whole theater team can see. And McGrath is nice and portable. You can take it anywhere with you. Now, let's move on. It also says external laryngeal manipulation, bougie, and removal of the cricoid pressure. Let's take this part in parts. So there are several types of bougies there, as you can see. Lots of different types of bougies, and could be confusing. The one in B is something called cam-elastic bougie, which we in UK used for many, many years. And it's good. It holds the shape, but the only problem with that, it has no lumen. So you cannot insufflate any oxygen through it. So I would suggest that you use Proba intubating introducer or bougie, which is hollow. So you can connect a rapid fit connector to it, connect it to your self-inflating bag, like an ambu bag, and you will be able to ventilate with difficulty, but still you'll be able to push some oxygen through that catheter, introducer, Proba intubating introducer. That's the proper name for it. Okay. Removing the cricoid pressure is something that is recommended because the cricoid pressure, if you perform it regularly, there is still a disagreement whether it should be performed routinely for rapid sequence induction. If you do it, then sometimes it can worsen the view. So if the view is worse with that, you can ask the assistant who is performing it to release it or to ease it off a bit. Let's move on to the plan B. And plan B specifically says use supraglottic airway device of a second generation. Okay, I hope most of you do understand the difference between the first generation of supraglottic airway device and second generation. So the first is the plastic laryngeal mask. Many other varieties and versions of the plastic laryngeal mask is just one lumen and a cuff. Basically, that's what it is. The second generation supraglottic airway device is fundamentally different. Normally it has two lumens. One lumen is for airway, another lumen is for gastroesophageal tract, through which you can insert a nasogastric type tube and empty the stomach while the device is in place. Quite often it has, like the one on the top picture, it has an anti-biting block as well. In other cases, in other devices, there is not even a cuff. For example, in iGel, there is no cuff there at all, so nothing to inflate, which is nice and easy and quick to use by any medical professional, not necessarily a trained anesthetist. So these two devices that we strongly recommend is one is iGel, and another one is Airways LMA Supreme, which is has a cuff, but not just one cuff. It also has two cuffs. One goes around like the normal cuff in the airway, but the other one goes at the back. So it's a double cuff. So this particular LMA will hold higher pressure, up to 40 centimeters of mercury of water, compared to a classic LMA, which only maintains about 20 centimeters of water. And an iGel is nice and straight, no cuff, two lumens, anti-biting block in both of them, and it's very, very easy to insert. And if it doesn't work, you just go for one size smaller or one size larger. So these are the second generation LMAs that are recommended particularly by DAS to use, because there are many other varieties. Okay, and then it says if you are successful in ventilating through a supraglottic airway device, you try and intubate trachea via that device. And lots of you, in my experience at the exam, know that when asked, what would you do? You say, lots of candidates say, I will intubate via the supraglottic airway device. But when we ask how, most of you don't know how. Okay, and I will explain in a minute. So you need something called the entry intubation catheter, the one in blue. Okay, an entry intubation catheter is specifically designed for this purpose, and that is the sequence of in procedure that you would use. So you first insert your laryngeal mask airway, ventilate the patient. Then you load the this entry catheter on your fiber optic scope, so you will need a fiber optic scope, and you put it through under direct control, under direct vision control, through your supraglottic airway device into the trachea. So you'll find the trachea. Then you will remove step number three is you will remove your fiber optic intubating bronchoscope, leaving the entry catheter in the trachea. You will then connect it to via the rapid fit connector to an ambubag, for example, and you can reventilate the patient if the patient desaturates, and quite often this is the case. Bring the saturation back, then you will remove your supraglottic airway device, connect it back, reventilate, and then you will disconnect it and railroad your endotracheal tube over your entry catheter, which will be in the trachea. It's long enough to be in the trachea, and it's wide enough. It's 4.4 millimeters of internal diameter, which means it's pretty much a good, long, but still good endotracheal tube without the cup through which you can ventilate the patient, reoxygenate the patient. And that is your aim, to continuously oxygenating the patient throughout the procedure. If your patient is desaturating quickly, then this device on top of the screen here in blue allows you to continuously ventilate the patient while you're performing the procedure, because it will go through with your fiber optic scope and the entry catheter mounted on it through this little rubber seal that will be tight around your scope and the entry catheter, and will allow continuous ventilation. Okay. Let's move on to a plan D. And plan D is the emergency front of the neck access. And DAS recommends that we use it as in scalpel bougie tube technique. And that is the technique that's described on the screen, and I will go through some of the elements of that. The first is to find where we will go with our scalpel. And that is suggested by this maneuver called laryngeal shake, where you would put your hand over the larynx, and you will kind of run your index finger in the middle, and hopefully you will find the thyroid cartilage below, which will obviously, hopefully, if it's palpable, you will find the cricoid membrane, and below which you will find your cricoid cartilage. It doesn't have to be that particular position, but it is the most avascular structure, the most identifiable structure, and it's the structure that we normally go through. But you can go between the tracheal rings as well, if the cricoid membrane is not palpable. And that's your sequence of events. You palpate it, you then put your scalpel in a horizontal position, then you turn it 90 degrees, and then you pull it through towards you, which will make a sort of triangular shape, through which you will insert your thrower catheter, thrower thrower bougie. And again, once it's in the trachea, you can connect it to the back and ventilate the patient. And then you will railroad your endotracheal tube number 6 over your thrower introducer, thrower bougie. Okay, that's your sequence of events. There are complications of this cricothyroidotomy, and then we can divide them into early and late. And early complications is bleeding. There will be bleeding, and there will be unsuccessful placement. There will be posterior tracheal wall perforation occasionally, so don't go too far in with your scalpel. You could produce a pneumothorax. Airway obstruction can occur, vocal cord injury, might be aspiration, laryngeal cartilage fracture, esophageal and mediastinal perforation, if you're forceful with what you're doing and you don't know what you're doing. Late complications are listed as tracheal subglottic stenosis, again, late aspiration, swallowing dysfunction, tracheoesophageal fistula, voice change, infection, late bleeding, stoma, tracheomalacia, all those. So obviously this is not an easy procedure, and we don't do it often enough, of course. And an average anesthetist does it 2-3 times throughout his career, and I've done my share. So if the patient is then can be woken up at whatever point, then you have a choice of what to do next. You can either do an inhalational induction with your patient breathing spontaneously, or you can do, sometimes it's possible to do this procedure under regional anesthesia technique, but quite often you will need awake fiber optic intubation. And this is what we're doing on this picture, awake fiber optic intubation. So NAP4, for example, revealed that in a lot of cases, colleagues discussed awake fiber optic intubation, but for whatever reason did not perform it, which caused later problems. So awake fiber optic intubation needs to be learned, needs to be practiced. On this picture, you can see us practicing on each other. This is the course that we run, not just we, but many other hospitals throughout Europe run, where participants learn this technique on each other after learning them on mannequins or computer programs. And then your other option is a surgical airway under local anesthetic. Sometimes even the fiber optic technique is not possible to perform. Okay, then we move on to what we do with intensive care patients. And I refer you to these guidelines, which were authored by this group from DAS, led by Andy Higgs, guidelines for management of the tracheal intubation in critically ill patients. And you might ask, is it different? And I would say, yes, it is. Intensive care unit and operating rooms are different for many reasons. Why are they different? Because the main difference is that intensivists cannot postpone the operation, unlike the anesthesiologist, who can say, okay, this is elective procedure, I'm going to wake him up, and then I will use an alternative technique. Intensivists cannot afford that, because intubation in intensive care unit is quite often, most of the time, is a life-saving procedure. You cannot just postpone it. And the incidence of death and brain hypoxia is about 50 to 60% higher, according to the reference that is at the bottom of your screen. So the ICU environment is different. ICU bed is not designed for airway management. It's big, it's wide, the access is difficult to it. Bed space is crowded with monitors, with other equipment. Access is limited, especially to the head of the patient where we normally stand. Lighting could be suboptimal. The airway equipment could be different from what you see in operating theater. This is why this is the picture from my hospital, where we have this particular trolley throughout all areas, including intensive care unit. And access to advanced equipment may be limited or delayed in the emergency situation. High flow oxygen devices may not be always available in intensive care units, believe it or not. And also airway assessment may be time limited, because time is precious when the patient is deteriorating. And medical devices like collars and masks and an altered conscious level and lack of patient cooperation may preclude you a normal assessment of his airway. There is a high aspiration risks in these patients. Patients often not fasted. Pathology and drugs can cause gastric stasis. Oxygenation with CPAP, non-invasive ventilation, pipe flow nasal oxygen may increase gastric distension, and nasogastric tube quite often is in the situ. And even if you aspirate through it before, which is recommended, it doesn't guarantee that your stomach will be empty. The airway of intensive care patients are difficult due to increased edema, trauma prior to intubation. It could be a tracheostomy failure where you will be dealing with. Urgency increases the difficulty, and statistically up to 6% ICU patients are admitted to the intensive care due to difficult airway, for observation, extubation, or for both. So they already have difficult airways. That's why they are an intensive care unit. And in these guidelines, what I like is the score that is called McCoha score. McCoha stands for Mallampati, M for Mallampati score of 3 or 4, A for apnea, obstructive syndrome, C for cervical spine limitation, O for opening of the mouth, which is less than 3 centimeters, C, another C for coma, H for hypoxia, and A for anesthetist, for non-trained anesthetist. And quite often there is a non-anesthetist as a resident on an intensive care unit. And it's the score is from 0 to 12, and the difficulty is increasing the higher the score. So if you assess the score and it's high, then it's a tricky patient and you need help of your seniors. Pre-oxygenation is quite often difficult. Pulmonary shunt in those patients interferes with effective pre and peri-oxygenation. Lack of cooperation is common. Delirium, reduced level of consciousness. They desaturate very quickly. Hence, I again repeat that you should use continuous oxygenation, or better call it peri-oxygenation. Like on this picture, this anesthetist is using high flow nasal oxygen or Thrive. Cardiovascular physiology of this patient is compromised. The collapse could be imminent even before the intubation at induction. Your standard induction drugs like propofol or thiopentone are not appropriate for this patient, and we'll speak about which are. Instability leads to time pressure, and you should use the pre-induction optimization of this patient, if at all possible. So induction agents are recommended, are ketamine, because this is the only drug that will not drop your blood pressure. And then rocuronium, because rocuronium is good, works quick, almost as quick as some dexamethasone, but more importantly, it could be quickly reversed with sugammadex. And proactive use of inotrope. If those patients are not on an inotropic support already, then prepare your inotropic infusions, or have your ephedrine, metronidazole, noradrenaline, whatever you have at hand to give these patients quickly, and allocate somebody who will be doing that. Like they do it on this picture. You can see there is 3 versions here: 6-member intubation team, 5-member intubation team, and 4-member intubation team. It could be one intubator number 1, intubator number 2. One is responsible for drugs and monitoring. Another one is for cricoid pressure and equipment. The runner could be opening your equipment, bringing additional equipment, and the leader who could be overseeing that. That is the optimal scenario, with as many as 6 members. And quite often on ICU, there are enough members of staff, but sometimes there aren't. So you can do it with about 4, and a minimum of 3, really. You don't want to do it with 2 people, because it's not enough in the intensive care settings. These guidelines also suggest this intubation checklist, which is really, really handy. Look at that. It's divided into 4 columns. One is to prepare the patient, a reliable access, IV access, optimizing their position, airway assessment. You can even mark now with ultrasound your crackthoracic membrane, optimal pre-oxygenation, patient state. You can give them bolus of fluids. You can start inotropic support, and then you prepare your equipment. You go through: do we have tracheal tubes of 2 sides, one up, one down? Do we have video laryngoscope? Do we have bougies? Is our suction working? Do we have supraglottic devices? Guedel airways, flexible scope, entry catheter. Do we have a front of the neck access set? Whatever set you use, I suggest Melka. Do we have drugs available? Is there a ketamine? Is there a muscle relaxant of choice, which is your rocuronium? Is there a reversal agent, sugammadex, available? Calculate the dose, get it ready. prepare the team, allocate the team to the tasks, and allocate the leader. Okay, and then prepare for difficulty, i.e., discuss your airway plan, verbalize it. Say, my airway plan, if you're a leader, is this. We're gonna do rapid sequence induction using ketamine, rocuronium. I will use video laryngoscope. My plan B will be supraglottic device. My plan C will be back to face mask ventilation. My plan D will be front of neck access. Do we have the scalpel bougie tube set available? Okay. Is there a scalpel? Is there a bougie? Is there a tube? Okay. And now we're moving on to obstetric scenarios with another guidelines that was produced by Mary Mushambi and her team in 2015, again, specifically for obstetric patients. And you might say, again, there's enough differences. Why there are different obstetric patients? For many reasons. It's because their mucosa of upper respiratory tract is more vascular, edematous. That increases the risk of airway bleeding and swelling. There is a decreased functional residual capacity of those patients. Hence, they desaturate very quickly, where oxygen requirements are higher. Their progesterone reduces the lower esophageal sphincter tone. Hence, they are predisposed to gastric reflux. There's a delay in gastric emptying during painful labor and after opioid administration. They have enlarged breasts. You might ask, why is this important? It's important because your laryngoscope may not be able, you won't be able to use the handles. Sometimes the breasts are on the way. You may need a shorter handle, particularly for obstetric patients. It's quite often out of hours. And decline in us doing general anesthetic means the decline in our experience of anesthetizing them, of giving them, providing the GA, because we quite often do regional anesthesia for them. So there is an algorithm which they have divided, this master algorithm, they have divided into three. Algorithm number one is called safe obstetric anesthesia. Algorithm number two, obstetric failed tracheal intubation. And algorithm number three, can't intubate, can't oxygenate. Let's take them in turn. So algorithm number one, safe obstetric general anesthesia. This concentrates mainly on preparation of the team. And a difference here is about their fasting status, because quite often they're not fasted. So you will give them antacid prophylaxis. It could be 0.3 molar percent solution of solution. It could be omeprazole. It could be H2 blockers like ranitidine. And then you normally would proceed with a rapid sequence induction. Again, checking all the equipment. And then the other difference here is that you only allow 2 intubation attempts with the inexperienced younger anesthetist, and the third one should be only by the experienced anesthetist. Okay, so you minimize number of attempts. And again, you would consider your video laryngoscope quite early. Okay. The table here, this table considers several factors: maternal condition, fetal condition, anesthetist, obesity, surgical factors, aspiration risk, alternative anesthesia, possible or not. And then depending on that, you will either wake up this patient or proceed with the procedure. So this decision could be quite difficult. It's quite a busy table. I don't want to go through this table, but basically this is the principle. You can read the whole table later on, because we're not going to fit it all into my presentation, but it's there for you. And the table 2 is management after failed tracheal intubation. What do you do when you woke that patient up? What do you do after waking up? And what do you do if you decided to proceed with the surgery? If it's emergency surgery, fetus distress, you'll maintain anesthesia, maintain ventilation. You will think about the paralysis with rocuronium. You will minimize the aspiration risk. maintain cricoid pressure until delivery. If you are not able to intubate, you can do it on a laryngeal mask, but with the cricoid on. You empty the stomach. Again, you would use a second generation mask. You would administer your H2 blocker intravenously, if not done before. Senior obstetrician should operate. Neonatal team should be informed about the failed intubation, and you would consider tonsil intravenous anesthesia for them. So, finishing my lecture, I'd like to give several conclusions. And conclusion table, slide number 1, planning. With your airway, you should be planning. If you anticipate the difficult airway, the planning is easier than when you don't. But planning is very, very important. So go through that table that was in the intensive care guidelines. That is very, very useful table, and that's all about planning. Ramping, I just reiterate that ramping is very important, particularly if your patient is obese. And then bringing the tragus of the air above the sternum is your aim, okay, with or without any specific device. Perioxygenation, not ventilation, what you should be concentrating on. Your patient is not going to suffer from hypercapnia up until a very, very long time, but your patient will quickly suffer from desaturation within a couple of minutes, 3 minutes. Okay, so perioxygenation is what we should be aiming at with the devices that I've already spoken about. Okay, muscle relaxants, if it's not working, muscle relaxants will help with vent. Don't be afraid of using muscle relaxants. They will help, but if at all possible, use those that could be reversed with Sugammadex. And it's not just rocuronium, there is also vecuronium if it's still available in your countries. Moving on, cricoid pressure off. If you're using cricoid pressure and it's not helping you, take it off. Your picture may improve. Video laryngoscopy, use it. We, in our hospital, like in some other hospitals in the UK, moved to a standard video laryngoscopy as our first choice. This is what our anesthetists use of all grades, but obviously the younger anesthesia trainees, we also teach them a normal direct laryngoscopy, but the first choice now is video laryngoscope, and it will happen sooner or later, but it will be standard throughout all operation theaters in the world. If you are to use a supraglottic airway device, use second generation supraglottic airway device that we've spoken about. It's iGel, for example. Entry intubation catheter is another device that is very, very useful for that very purpose. If you're ventilating through iGel, if you're ventilating through airways, LMA Supreme, or any other second generation device, then that catheter, entry catheter, will help you to secure the airway within the tracheal tube. Without it, it's impossible to do it through supraglottic airway device. And that will what we are asking you during the examination to describe to us as well. So learn how to perform front of the neck access, and ask yourself, is my scalpel bougie tube set, put together, and available in all those locations where I intubate, in all my operating theaters or anesthetic rooms or whatever setup you have? This is ours. It's in one pack. You will find a scalpel size 10, and you will find a bougie there, and you will find size 6 tube. And not just any bougie, it will be Frova Polo bougie. And all I have to say to an anesthetic assistant, anesthetic nurse, an ODP is bring me set, scalpel bougie tube set. In our case, it's called can't intubate, can't oxygenate set number 2. And they will bring it, and it's all there, because we've done the audit in the past where before we put it all together to bring this 3 devices to us, and it took up to 2 minutes for them to appear because they're not usually put together in one set. So that's what I would recommend you use. Put them together. It will then be very, very handy if you need them in a hurry. Thank you very much for your attention. Good luck with your examination. I have finished, and hopefully we will see you among the graduates and among the diplomas of the European Diploma of Anesthesia and Intensive Care. Thank you for your attention.